recently reported STITCH trial compared medical management to surgical therapy in patients with ischemic cardiomyopathy and showed that a myocardial viability study done preoperatively made no difference in outcomes. To me, this seems counterintuitive, but that is what the study showed. Now in the American Heart Journal, there is another report which supports this finding. Researchers went back to the data from the OAT trial, which evaluated PCI against optimal medical therapy in patients with persistent total occlusion of the infarct-related coronary artery. They looked at 124 OAT patients who had sestamib-SPECT viability studies and who had follow-up studies at 1 year. Then they evaluated infarct size, viability, ventricular volumes, and ejection fraction. 70% of the patients studied indeed had moderately retained infarct zone viability, but at 1 year there were no differences in left ventricular volume changes between those treated with PCI or medical therapy. Interestingly, and perhaps not surprisingly, increased baseline peri-infarct viability predicted improvement in ejection fraction, but the treatment used made no difference. You would think that reopening an infarct vessel might make a difference, but it did not. My take on all this is that our present medical therapy for ischemia seems to be pretty good, and outcomes are pretty similar to revascularization outcomes, either by PCI or surgery. But more importantly, this raises the issue of whether we should be doing so many viability studies to help make treatment strategy decisions. I plead guilty to being one of those cardiologists that likes to know whether my patient has viable myocardium before committing them to revascularization. But maybe I should just make the decision and not increase patient care costs by avoiding so many viability studies. And maybe I could not send them for revascularization at all. I'm Peter Block, and this is a CardioSource Heart Minute.